All right. So the carotid duplex exam. Um, so there's specific protocols that are standard for doing a carotid duplex exam. So these are images that are going to be required of you no matter where you go. There's same basic standard images, and it involves, starting in your transverse view and doing a transverse sweep, starting at that proximal CCA and just working your way superior to mid CCA, distal CCA, bulb, and then the bifurcation. You'll also put color Doppler as you're doing your transverse sweep. So showing 2D with 2D and with color and transverse. And then you do a sagittal assessment starting at CCA, proximal CCA, and just working your way up in sagittal now, up the common carotid, getting to that bifurcation. Every lab will have you do image showing distal CCA bulb and then proximal ICA, and then distal CCA bulb and then proximal ECA as well, both in 2D and color. And then after you've established or captured those images, then you move on to imaging your internal carotid artery, and you continue up your internal carotid artery as distally as you can go. After you've assessed your internal carotid artery, you then will also have to image vertebral artery. Every carotid exam should be performed bilaterally unless you're going up to the OR and they're doing an endarterectomy. If you go to do this exam portably and the patient has a line in their neck, ask the doctors, is this something you guys still want or still need, or because you really can't assess if they've got a triple lumen catheter and overlying dressings, on the side of their neck. Ask them, if this is something you guys still want or still need at this point, because you really can't get an accurate assessment if you're not able to look at both sides. The transducer is our high frequency linear probe. So that's our go-to probe that we always use. We're going to utilize color flow, our color Doppler, pulse wave Doppler, be measuring our velocities. So with our velocity measurements, we're always going to acquire peak systolic and end diastolic velocities. We're going to also assess those waveforms, for the waveform characteristics, nice open spectral windows, nice fast upstroke, no evidence of spectral broadening, any signs of turbulent flow. When we want to assess the bulb, I see a lot of techs sometimes switch over to that power Doppler mode or power angio and throw power Doppler on the actual bulb itself. So this will help to determine if there's actually any plaque in that bulb, or it's just an issue with a slow flow state. So maybe that patient has a low cardiac output, weak heart. The velocities are just very slow. Once they enter into that bulb, things start slowing down. And it may look like that bulb is not filling with color, and there might be some hypoechoic or anechoic soft plaque in there, or it may look like there's soft plaque in there when in actuality it's just a slow flow state. So I've seen a lot of techs sometimes just switch to power when they acquire that image, get a nice power Doppler image of the bulb completely filling with color. And then we can also utilize harmonics to improve resolution. So always press your harmonics button when you're doing your carotids. It'll help give you a nice, clean, sharp image. So these are just some common indications. So anytime we're again doing an ultrasound exam, we need our indications. So an asymptomatic bruit. So maybe they were examining the patient, they heard a bruit on the patient's neck. So again, that bruit indicates turbulent flow. So that could be an indication for us doing that exam. Any sort of territorial or non-localizing symptoms. So all those symptoms that we went over and discussed in previous class, all the stroke symptoms. Screening for cardiac surgery or even potential vascular surgery, but cardiac surgery is a big one. We often get called to do carotid duplexes on patients that are pre-op for CABG, for coronary artery bypass surgery, if they're going for double bypass, triple bypass, any sort of heart surgery, valve replacement surgery, TAVR. So a lot of these heart surgery patients, the cardiologists want us to do a carotid duplex. The reason being that particularly with coronary artery disease, there's a strong correlation to carotid artery disease. So if a patient's got bad coronary arteries, they may have bad carotid arteries. And if they have significant blockages in their carotid arteries, that makes the surgery much more high risk. They're much higher risk for potentially stroking out during the surgery, maybe having embolic events, plaque breaking off, because they're going to be on these bypass machines. So it might make it more challenging. And they may, if it's severe enough blockage or stenosis, they may actually elect to take care of their carotid arteries at the same time while they're doing the cardiac surgery as well. So clean out the carotid arteries, do the bypass, or maybe even do the carotid arteries first and then do the bypass surgery for the heart. Again, any history, known history of a stroke or transient ischemic attack, those mini strokes. If they potentially feel a pulsatile mass. We want to, our indications, we can, if they have a known stenosis or occlusion, we can determine the percentage of the stenosis or occlusion. And follow that patient, do follow-up exams to see if it's getting worse, how significant it's getting. That's the thing about carotid artery disease. It doesn't get better. So once you develop significant carotid artery disease, it's just a matter of trying to slow its progression. So it's never really going to reverse on you. We follow up previous exams, and we can do it as follow-up, post endarterectomy. So that's that surgical removal of the plaque, where they remove the actual atherosclerotic plaque, cut open the neck, remove the plaque, sometimes even a portion of that intimal lining, or follow up after maybe they placed a carotid stent to try and open up the vessel. So position, we want them supine. They could be reclined a little bit. So I know some patients can't lie completely flat. So we can have the back of the bed up a little bit. And then we just want them to kind of rotate their neck out as far as they can to really just open up the side of their neck. If they're able to drop their shoulders down, just kind of relax, just kind of open up, your window as much as you can. Have them relax. So this is something that I personally don't see very much anymore. A lot of the old school techs got trained to scanning a carotid seated at the patient's head. This is actually probably the most ergonomic position because like the patient's head is kind of like up towards you. I think I have a picture. Here you go. So here's the picture of how you kind of seat yourself to scan a carotid artery. So you're just kind of scanning up towards you. You're seated at the patient's head. But I've yet to see people like Cristiano or anyone, even in New York, scan it like this. I think there was one guy that did it like way back when, but that's not very common anymore.
How come?
Just
like,
sometimes
it actually does look
it's easier,
yeah.
It's just I guess it involves just having to move around the stretcher and the machine, just reorganizing the room, and so
Okay.
they just don't want to bother doing that. So we have a couple of different approaches that we can attack the carotid arteries or scan through. We can come from an anterior approach, we can come more lateral, and we can even come more posterior or posterolateral. So this is kind of showing the different orientations of your vessels coming from these various approaches. So just be cognizant, if you don't get good images and you don't feel like you have a good window coming from anterior, just slide over lateral, see if a nice lateral approach works better and you can see that clearer. If they're really deep, it may become more posterolateral, come from more posterior and angle back up towards them. This is just showing our transverse probe position. And then this is anterior, coming from the patients from the front of the neck. More lateral, and then more posterolateral. So coming basically behind that sternocleidomastoid muscle and angling back forward at it. Yeah. Oh, okay. I'm getting kicked out. You want me to turn that way? You want me to turn the other way? All right, all right. Okay. It's funny. She's like, why'd you set up shop in the kitchen? Or like in the sunroom. She doesn't want to be on camera. There we go. All right, so the study is always done in a sequential way. So that's the nice thing, you're going to just get used to just following your sequence of images, and it becomes second nature over time when you're doing a carotid scan. You obtain your patient history, your signs and symptoms, because again, your signs and symptoms play a big role in determining what could potentially be the vessel that is affected based on those signs and symptoms of the patient. And we need those proper indications for exams. So every carotid study is done in both transverse and longitudinal. In transverse, again, we start with our CCA, start proximal, just work our way up to distal CCA. We do our bulb and our bifurcation, identify ICA and ECA. So this transverse view is essential for us to assess the thickness of the plaque and the degree of luminal narrowing. So in that transverse view, we can get a nice 360 view of the vessel, and we can see all walls of the vessel. We can see how much plaque is along all of those walls, and we can determine the degree of narrowing. So how narrow is that residual lumen? How tight is that vessel? So how narrow is the vessel, and how much blood flow is getting through? So that's what we can assess very well in our transverse view. So if we're trying to just assess in a sagittal view, we might be slicing it, and we're slicing it kind of at an off angle. We're not clipping that plaque and being able to assess the full degree of luminal narrowing in our longitudinal view. We might underestimate or severely overestimate, depending on how we're slicing. Let's see how I get on here. Thought I heard Brian come in. No. With our longitudinal imaging, we're going to do grayscale, color, and Doppler. So we only have our Doppler and sagittal. There's Brian. Again, so we start with CCA, just work our way up the common carotid artery, proximal, mid, distal. We're going to do our ICA, prox, mid, distal. So I like to just personally, for me, do CCA, then ECA, because we only Doppler ECA once at the proximal segment right near that bifurcation. So I do CCA first, then I do my ECA, get that out of the way, and then I continue following ICA up proximal. So then I'm not like kind of coming back down and trying to find ECA again, get a nice ECA image. I just do ECA and then move on to ICA and then continue tracking ICA up. And then ICA, we're going to do grayscale, color, and then Doppler, prox, mid, and distal as far up as you're able to image. Again, this ICA is all going to be dependent on the patient and their anatomy. It seems like all of you guys have very high bifurcation, so that segment of the ICA isn't that long. I mean, we can see some pretty good, a fair amount, but some patients will have that bifurcation kind of around mid neck, and they'll have a nice long ICA that you can track up. After we've imaged CCA, ICA, and ECA, we then will learn to tilt back and image our vertebral artery. So we just pick one segment of that vertebral artery, and we try and we just obtain a color and a Doppler image. The main thing with the vertebral is just pretty much assessing if that flow is antigrade, normal flow direction, or if it's retrograde, if there's potentially the presence of subclavian steel. So that's really what we're looking at. You might get a little bit into your report if you want to write, vertebral demonstrates a high resistant waveform. That could potentially indicate a more distal obstruction that's causing it to be high resistant. So if that's something you note or appreciate while you're scanning vertebral, you can mention that in the report. But we'll learn that there's no stenosis velocity criteria for vertebral arteries. There's no stenosis velocity criteria for the ECA or the CCA. It's just the ICA that has these velocity criteria for determining the degree of stenosis. If we do happen to notice that there is retrograde flow in that vertebral artery, then it would be indicated for you to also try and image the subclavian artery as well. See if you could see that proximal subclavian artery, or if it's on the right side, see if you could see the patient's innominate artery and proximal subclavian to see if there is a high-grade stenotic lesion in that area that would potentially be causing, that retrograde flow in that vertebral artery. So that is under the scope of your discretion and scope of practice to look at those vessels. So oftentimes they say, don't go off your script, don't start, imaging stuff that, it's not part of your standard exam. So that subclavian artery would technically be part of your standard exam if you happen to notice retrograde flow in your vertebral. So you are okay in doing that. This is just showing a transverse view, starting at the CCA and working your way up to the bifurcation on the right side. So if you kind of just envision patient's head, turn to the right, we're imaging the right carotid artery coming up. We have CCA, and then that internal jugular vein should be anterior to that CCA, more superficial. And when we get to that bifurcation, the ICA, typically larger and more posterolateral. ECA is more anteromedial. As it splits, this is kind of going off towards the patient's face. This is running more posterior.
Wait, Dan, for ECA, do you need to turn the probe more medial towards the patient's head to get it?
Usually more towards the patient's jaw.
Oh, okay, so more, okay.
Yeah,
gotcha.
or their face.
Okay. Is it usually hard to find?
ECA?
Is it, yeah, I feel like Brian's was kind of hard to find because I don't know,
Is it?
his split wasn't.
Yeah, so if I'm coming up, I'll kind of either turn this towards his face, the top of my transducer towards his jaw or his face to try and get ECA. Sometimes it's just tilting towards his face, angling towards his face. Sometimes it's just a little rotation. Each patient's a little bit different. So ICA is usually more posterior, so I'll turn the top of this more posterior, maybe towards the ear versus towards his jaw. It just takes a little practice, but eventually once you get the hang of it, it's really not bad at all. So in terms of getting measurements, we want to make sure we have a nice 2D image. So it all starts with our nice clear 2D image. For me, this is a little too much wasted space. I would have really brought this in a lot more. So we have a nice clear 2D image, try and visualize those luminal walls. So you can see the intimal layers on both sides of the vessel here. So you're directly perpendicular. The Doppler sample volume is in the center of that artery. So that doesn't look very good. I would move that more into that center up there also. This one's good. That's nice in the center of the vessel, this bottom one. And then our Doppler angle. So that's the big one. We want to make sure our Doppler angle, as much as we can, try and keep it at 60 degrees. If we do have to deviate from 60 degrees, make sure we're angling down, or make sure it's less than 60 degrees. We don't ever want to go over 60 degrees, because when we start doing that, that Doppler shift increases exponentially, and we'll be overestimating the Doppler shift. The Doppler signal is we want to make sure that we have a nice, strong, and clear Doppler signal. So nice spectral window, nice clear signal, nice tight, sharp envelope. And And when we Doppler CCA, we start proximal, we do a mid CCA and then a distal CCA just before the bulb. So this would be distal CCA. We can see over here the carotid bulb where it starts to bulge and dilate a little bit. So we're going to Doppler just before that bulb for our distal CCA. So that distal CCA measurement, that velocity measurement is important for us because we also calculate something called a carotid ratio, where we compare the velocity in this distal CCA to our proximal ICA, or our fastest velocities in our ICA, to get this ratio. That's one of the criteria that we can use to help determine the degree of stenosis. So we'll see that in a moment in our little chart. So this is just showing the relationship of our ECA and ICA, how every patient's a little bit different, how it bifurcates. So it could be top to bottom, could be side to side. And that will dictate, your longitudinal image that you're able to acquire. So if they're top to bottom, these are the patients that we can get that nice tuning fork where you can see both ECA and ICA clearly in one nice picture. So here again, we can see another bifurcation, that tuning fork view. We have our ECA and our ICA. Ours are just pointing to some atherosclerotic plaque within the bulb and that proximal ICA. So if a patient's bifurcation is side to side on our transverse view, it's not going to be possible for us to get that nice tuning fork. And we're going to have to image the ECA and the ICA independently of each other. So this is that image that I was saying that every lab will require you trying to get that distal CCA bulb ICA, proximal ICA, and then CCA bulb, and then proximal ECA. So you're going to try and get these views or these images independently of each other. When you guys get to Riddle, and when you guys do rotate through Riddle, they actually do a cine clip, and they have the technologist kind of angle back and forth between ECA and ICA, ECA, ICA, to kind of show the radiologist or the doctor that's interpreting the two vessels. That's something that maybe we can practice. I know that some of the students last year said that was something that they wanted a little more practice on, just working on trying to get that clip of shifting back and forth between ECA and ICA. So walking the Doppler cursor from distal CCA through the bulb into the ICA. So to be honest, most labs and most places don't actually Doppler the bulb, just because the flow patterns in the bulb can sometimes, well, they are disturbed. They're not indicative of true velocities. The only time I would ever really Doppler the bulb is if I saw a stenotic lesion within the bulb. If I saw a significant amount of plaque, turbulent flow going through that bulb, then I would try and get velocities through that bulb. But if the carotid arteries look healthy, there's very minimal plaque, if any at all, just Doppler your distal CCA and then move right on to your proximal ECA and then continue with your ICA going up. So ICA evaluation. So the ICA may have some distortion due to that bifurcation. So if we Doppler the ICA and we're close to that bifurcation, that bulb and that bifurcation, our ICA waveform might look a little turbulent. We might not have a nice clear spectral window. Might not be as sharp as we expect, but as you start working your way slowly away from that bulb and that bifurcation, the ICA waveform will take on its more telltale characteristics, where we get a nicer, cleaner spectral window. So we get a more typical ICA waveform appearance. So don't be alarmed if you're Doppler in your ICA and you're really close to that bulb bifurcation that looks a little funky. We don't have that clear spectral window. We look like we have some spectral broadening. That's normal. So that's fine. And then we get a more return to our laminar flow as we start working our way more distal from that bulb. So this was showing recording of data. So here, if you notice these little check marks, these are the velocities that they selected to create this velocity ratio. So we'll learn in a little bit what this velocity ratio represents and what it could be used for. But it's the distal CCA velocity. Proximal ICA velocity divided by that distal CCA velocity to get this velocity ratio. So we divide the peak systolic velocity. So this is the systolic velocity ratio. We divide that ICA peak systolic velocity by that CCA, distal CCA peak systolic velocity. So the reason they can use this is if when we have our chart for determining ICA stenosis on here. This velocity ratio can be used to determine the degree of stenosis. It's just kind of one more factor that we can use to say, all right, this patient has a 50 to 69% stenosis, or is it greater than 70% based on this velocity ratio? The reason we use this ratio sometimes is if patients have low cardiac output, if they have a weak heart, and those initial velocities aren't fast enough to fall under our criteria. So I think Brian kind of encountered something like this where the velocities that they were measuring didn't fall into the criteria for a certain degree of stenosis, and the tech actually measured and did some fancy calculations to determine the degree of luminal narrowing. But you can also potentially use this ratio. So for instance, if like what is it? ICA is like 100 and CCA is 20, like the velocities are very low. 100 wouldn't fall under that criteria for hemodynamically significant stenosis. But if you're going from 20 up to 100 between two segments, that's a 5-fold increase. And we'll see that a 5-fold increase would indicate a greater than 70% stenosis. So that's why sometimes we utilize this ratio. So maybe a patient has very low blood volume, they're hypovolumic, or they've been bleeding out, and their velocities are very low. Or again, if they have a very poor or weak EF, their EF is 20, the heart's barely beating, that's not going to pump blood very fast, into the carotid artery. So they'll have very low velocities throughout their body. So that's why they might potentially use this velocity ratio to determine degree of stenosis. This is that carotid exam. We start grayscale transversely, then we do color trend. Yep.
Quick question, Dan. Sorry I was late, but
Oh, that's okay.
What if is this sort of the velocity ratio sort of saying that we're thinking there's a stenosis in the bulb area, or we see that, but what if, so we wouldn't use this ratio if there was only stenosis in like the distal ICA or further up?
That's much less common to see it in the distal ICA, but you could. Christiana, they use whatever segment of the ICA has the highest velocity and put that in their ratio.
Okay.
You still always use your distal CCA as your kind of your baseline. Your denominator is going to be your distal CCA velocity. They put in the fastest ICA velocity or the highest ICA velocity, whichever segment. So if it's mid segment that you're getting your highest velocity, they'll throw that into that equation.
Okay.
I was always taught to use proximals, CCA, but in this case, if you look at these velocities, that proximal ICA, that's actually the highest velocity out of those choices. So they use distal CCA and then the highest ICA velocity, which happened to be proximal.
Okay. All right, that makes sense. Thanks.
So our exam, transverse, grayscale, then transverse color, then grayscale longitudinal, and then color and Doppler and longitudinal. So on the right side, we want to survey that CCA approximately, see if we can see it actually joining into that subclavian artery and the innominate. See how far down proximal you're able to go. And then we just move distally. Going to acquire our 3 images, prox, mid, distal for CCA. On the left side, we need to survey the CCA as proximally as possible before moving distally. So at A and B, the right side, we can see the CCA joining that innominate and the subclavian. So we can see our proximal CCA right at the origin. On the right side. C and D, the left side going proximally. So we can see the CCA fairly proximal, but we can't, most of the times we're not, or I'm going to say yes, we don't ever really see the origin of our left CCA just because that is originates from our aortic arch. So we want a nice transverse picture then after we finish imaging CCA of our bulb. And then we get a transverse grayscale of our bifurcation, our ICA and the ECA. Then we want to work on getting nice transverse color pictures. So we'll get a little practice. So doing these transverse color pictures, we want to optimize our scale, make sure that vessel fills completely with color. So I'm not too big of a fan of this. Looks like we got a little bit of bleeding in some areas that aren't filling nicely with color. So maybe play around with this, try and get it filled nicely with color without having it bleed outside that vessel. Same thing with this one. Like, is this plaque that's in this bulb here? Or is this really all that's filling with color? Or do we just have to come down with our PRF, with our scale now to have this fill more with color? Maybe try doing power Doppler to see if this actually all fills with color when we put our power Doppler on, or is this really, hypoechoic soft plaque that we're seeing? We don't know. So we'll learn to, when we're imaging in transverse, to get it filled with color, all we do is just put a little bit of tilt on the transducer and it fills a little bit better with color. We'll get in the habit of doing that.
Would you say that sorry, the last picture, the IJV, would you say that that's a good image? Because it kind of looks like a pseudo aneurysm with the color fill. Like, so would you say that that's a good
Well,
or
I'm not really worried about the IJ, like in terms
Okay.
of our study.
looking at the
Um,
bulb?
Yeah, we're focused. I mean, the bulb, the carotid is the focus of the study.
Yeah.
If you happen to find thrombus within the IJ, yes, document that. So if there's
Okay.
DVT in your patient's jugular vein, you find a clot in there. That's happened to me. I've been doing a carotid, but like, oh god, his IJ's thrombosed. Yeah.
Mhm.
So then you can go down that road and image. Yeah, maybe just a little tilt will make this all blue. You can even, if you wanted, compress this out and you just have the bulb in your picture. So that's always an option too. If you ever want to get veins out of your picture, just compress them out and just image your arteries.
And would you use power Doppler too, maybe? Or not?
You could, yeah, I would. In this case, like if I thought this was potentially could be plaque, I would put power Doppler on just to make sure. Yeah, with power Doppler, if this wasn't plaque, it should fill completely with color. If everything was optimized, my scale was set correctly, and I did everything, my gain was, high enough. Maybe they just have to turn their color gain up a little bit more. Maybe they just have to lower their PRF, maybe just tilt a little more, switch to power Doppler. Try and get those vessels to fill, if possible. I mean, you don't want to do it where you're bleeding out and then like blooming and actually masking plaque. So you don't want to do that, but you also want to just ensure that this is real, what you're seeing.
Yeah, I know. Goodness, I've had like, there's a Kirsten and a Kristen, and then I had another Kirsten, the tech at Eden Hill Vascular. She did a lot of power Doppler in longitudinal as well, but it was like fine adjustments just to, like you said, make sure it's not bleeding out over the vessel wall, so you know that it's accurate. And
Yep.
she just moved so fast, it was hard to really, even though she explained a lot of things, it was hard to know exactly what she was doing.
Yeah. So then just move it up superiorly, we then get into our bifurcation. Anyone want to guess what this little guy off to the side could be?
The thyroid.
Yeah, it could be superior thyroid artery. Yeah, definitely a possibility. It's definitely a branch off of our ECA. So yeah, that could be superior thyroid artery. Good. Grayscale. So after we do our transverse sweep, we move to grayscale, just working our way up. CCA, proximate distal. Get into our bulb and our bifurcation. So this patient's got a nice tuning fork, makes life easier. So in this case, they weren't able to see that nice tuning fork, so they focused on just getting that ICA, so CCA, distal CCA, bulb, proximal ICA. Want to do a nice color imaging coming around. So after we do a grayscale imaging, going up to our bifurcation, we then do color. So color can be done in Doppler at the same time. So with each segment, so you can start proximal CCA, color, and then Doppler, and then just kind of work your way up to mid segment, color, Doppler, distal CCA, color, Doppler. I'm not a fan of these color pictures, you know, like angles slightly off a little bit, but you know, what's this going on here? Like, is this really plaque here? Looks, they're making it look like there's plaque in that vessel. And particularly these as well, you know, and this looks like plaque along the vessel walls. There's like maybe hypoechoic soft plaque. These aren't very good images. We're going to get much nicer images than these.
Do you think it is plaque, considering there's like little notches within the color, or is it just a terrible image?
It's hard to tell. I mean, the fact that they have all this soft plaque is for me kind of unusual.
Okay.
Like particularly going all the way down into like it seems like it kind of runs through all their vessels. Yeah, I just don't think it was optimized properly. Maybe they just need to steer a little more, adjust their PRF, adjust their color gain.
Well, yeah, I mean, it didn't even look, if you go back, I mean, it's just bleeding up into the next one where you just were bleeding up it. No, maybe it's my screen. I'm only seeing the way I have it set up.
Which one?
I don't know. I concur with what you were saying. So
Yeah,
can I brag real quick?
sure.
I went to the Wilmington campus, which was really nice. The security guy was a little crazy, but printed out the slideshows in a
Nice.
binder. Thank you. That's all.
Did it cost you money or was it free?
No, I could have stayed there for probably another 2 hours and printed out a whole bunch of other stuff, and then you could just ask for more paper, and there you go.
So then we're gonna, after we do our CCA, proximate distal, I like to do ECA and then move on to ICA. Here we just have ICA next, but I like to just do ECA, be done with it, and then follow the ICA up. So here we're just showing proximal ICA, and then distal ICA. So just for our comp, we're just gonna do proximal and distal. but in the labs, you'll always do prox mid distal. So just appreciate slightly difference in the waveforms between proximal and then distal. So in that proximal, it looks almost like it's like a little bit tardis parvis. It's not as fast as an upstroke. It's because here we're still close to that that separation, that bifurcation. So we don't have that true laminar flow yet, and then we get a nice return to nice laminar flow as we move more distally away from that bulb. So that ICA waveform starts to change just a little bit, so it has a little bit different appearance to it. So this is just showing that distal CCA bulb and then ECA, that other image that you need to get. And then our nice ECA waveform. So we only ever Doppler this proximally. That doesn't look like a very good angle at all on that as well.
Hey, Dan.
So yeah,
I'm sorry. The slide ICA waveform proximal, mid, and distal. They're both labeled distal on the right. Is one supposed to be
Yeah.
mid or?
this top one looks like it's more mid. This definitely is proximal. It looks like we're right near that bulb.
Okay.
This one looks like it's getting away. Yeah, they labeled it distal too. But then this one looks further down.
Okay.
See, I don't agree with that too. I would have moved my color box over to the edge. This vessel probably continued going down here. I probably could have imaged even further. So I always tell you guys, go as distal as you can. Like move your color box over to the edge, see how far up you can go, and then call out your distal. You know?
Yeah, Kirsten complained about that too. With she had a visiting tech when I guess she was out from like last year, and she remembered this study where the guy put like proximal, mid, and distal, and he wasn't
like-
even to the mid.
Yeah.
So it skewed this patient's results in terms of degree stenosis and velocities and everything. And so when she went back to look at this guy 6 months later, she's like, oh no, see, this is yeah, okay.
Yep. Yeah, it'll piss you off when you guys start working and you see shoddy work. You're like, oh god, man, what did they do? Like, so again, that ECA is only done proximally, so that's why I like to just get that done out of the way. Get my proximal ECA with our color and Doppler, measure your peak systolic and diastolic, and then I focus on the ICA and just make that the focus of my study and continue the ICA up. For me, it's just easier. And then after we finish imaging the ICA all the way out to distal, I then do vertebral artery. Vertebral artery, the best way to find it is kind of just come to mid CCA and then just start angling posterior, slowly start tilting back on the patient's neck. And then your vertebral artery should come into view. So you should be able to see those spinous processes where you get this shadowing and then a segment of that vertebral artery as it's running in between your vertebrae, your cervical vertebrae. So we don't actually see the vessel when it's running in that vertebrae and that spine. We just see the segments of the vessels that are outside of the individual vertebrae. So you just pick a nice segment, Doppler it, do a color, do a Doppler. And we should get a waveform that looks pretty similar to our ICA waveform. Again, the main thing for this is determining flow direction. Is it antigrade, normal flow direction up to the brain, or is it retrograde? So our interpretation now. So when we're doing our grayscale interpretation, we want to characterize plaque formation and measurement of percent of area or stenosis. With color flow, we want to locate the areas of stenosis and vessel course. We use color flow to also determine the direction, recognize abnormal color flow patterns. So do we see any turbulent flow, any areas of aliasing? Again, utilize that power Doppler, the color angio, to differentiate either between severe stenosis versus the occlusion. So if we come to a carotid artery and it looks like it's occluded and completely blocked, always put your power Doppler on to verify if it truly is completely occluded versus just high-grade stenosis with some trickle flow. With our special Doppler, we want our Doppler angles to be at 60. If we have to deviate from 60, make sure we're turning it down, so under 60. We want our sample volume gate to be fairly small and in the center of that vessel. And we want that Doppler angle aligned to that vessel wall or parallel to that vessel wall to ensure that we have the best Doppler angles. If we do encounter a stenotic lesion, if they have a high-grade stenosis, we're going to want a Doppler before that stenosis, within that stenotic zone, and then on the other side of it. So it's going to be at least three Doppler measurements. I usually do 4 if it's a high-grade stenosis, particularly if I'm kind of on a cusp between 50 to 69 and greater than 70. I'll sample multiple times trying to find my maximum velocity within that stenotic zone. So a nice trick when you encounter a high-grade stenosis is really turning your PRF, your scale, all the way up. And then it'll really narrow that, you'll see a narrower jet of aliasing or turbulent flow through that stenotic lesion. And it kind of give you a good place to put your sample gate right on the center of that stenotic jet. So just turn your scale all the way up. That'll help reduce a lot of the excess aliasing and kind of narrow that central highest velocity flow. And you can be able to Doppler it a little easier to try and find your maximum velocities through that stenotic lesion. You're always measuring peak systolic and end diastolic velocities. And we're going to calculate those velocity ratios. So there's a couple of different criterias. So this is an older one that graded out carotid arteries. So this is University of Washington criteria. So the only time you can ever call a carotid artery normal is if there is no plaque at all. So as soon as you see even a little speck of plaque, even if it's the most tiniest amount, you cannot say that that carotid artery is normal. So you have to, the way they grade it out, they would say less than 50% stenosis. So even though that's a really huge range, all the way from 1% all the way up to 50%, you would have to say less than 50% stenosis seen in the patient's ICA. So when we grade it too, we're talking about the degree of stenosis within the internal carotid artery. So we don't grade stenosis in the CCA. We don't grade stenosis in the ECA. It's just the ICA that we grade these stenotic lesions.
So most likely, all of us are going to be normal.
Hopefully, yeah.
Okay.
Brian, you were fine.
Yeah,
Bystander.
yeah. I've seen too much in clinical. So
This is just another criteria, this Bluth criteria. Again, just showing some of the breakdowns. These aren't typically utilized. Let's see, I want to get to the one that is utilized.
I need more coffee. I'll be back.
That's okay. My chart. So I kind of just jumped ahead. So this is the consensus criteria. So this is the chart that you're gonna find in most ultrasound labs. This is what the boards will question you on, knowing that these velocities, being able to understand this chart. So this chart is something that, you know, you guys are gonna eventually have to just commit to memory. So this is what they use to determine ICA stenosis or degree of stenosis. So again, normal is with no plaque. Less than 50% stenosis would be a little bit of plaque, but peak systolic velocities for that internal carotid artery are less than 125 centimeters per second. The next criteria or the next range breakdown is 50 to 69% stenosis. These have peak systolic velocities between 125 and 230. And then the next criteria or next range for stenosis would be a greater than 70% stenosis. So we say less than 50, normal, no plaque, less than 50, 50 to 69, or greater than 70. Greater than 70 would have a peak systolic velocity of greater than 230 centimeters per second. There's also an end diastolic velocity component to that as well. So in terms of remembering those, normal and less than 50 would have an end diastolic velocity of less than 40. When we start getting into hemodynamically significant lesions, those are our 50 to 69 and greater than 70. So these two criteria, we classify those as hemodynamically significant lesions. So once we get into that criteria, the end diastolic velocity for 50 to 69 is 40 to 100. And then greater than 100 for your end diastolic velocity would be a greater than 70% stenosis. We can also utilize that ICA to CCA ratio as well. So we can use that in cases where, you know, the patient has low EF, low ejection fraction, weak heart. Those velocities are not very fast. They don't fall under these peak systolic velocity criteria. So we can use our ratio. But typically, like if you do have a greater than 70% stenosis, like it's greater than 230, this is gonna, you know, these will also happen as well. They should happen as well. So this peak systolic velocity is like our main criteria. That's the main thing that we use, but we can use some of these other supportive ones as well, you know, to try and figure out if there is, you know, a significant stenosis.
Wait, why is less than 50% a normal? For the stenosis on the left side, the same for the peak systolic. Like that doesn't really. Yeah, why are they
So
both?
it's not until we get up to over a 50% blockage that it actually affects the velocity. So we don't really see velocity increases, and they're not considered hemodynamically significant. So if a patient is 45% blocked, even 49% blocked, those velocities shouldn't increase. We shouldn't see an increase in velocity yet. Once we cross over that 50% threshold is when we start seeing those velocities starting to go up. And that's what we use to indicate, you know, this degree of stenosis or blockage. So normal and less than 50, it's fine. You know, it's not considered hemodynamically significant. They just have some plaque. And we shouldn't see velocities over 125.
Okay, so what if it was over 125? Is it always like typically gonna be less than 125, even if it's less than 50% stenotic? Like, is it still possible for you to be less than 50% stenotic and still have a high peak systolic? Isn't that possible?
Yes. So it's funny that you mentioned that. So my doctor, Dr. Pellerito in New York that I worked for, he sits on the board that this consensus committee that and makes you know, these protocols and these recommendations. Last year, they came out with new recommendations for new velocity criteria. So right now it's just recommendations. It hasn't really been implemented in a lot of hospitals. Bay Health, I believe, does implement the new velocity criteria. So the new velocity criteria bumped up these numbers now. Because they've realized that 125 is really too low. Like if I Dopplered Andrew or I Dopplered you, Sydney, you guys are probably over 125 because you are young, have young, strong hearts. So your velocities probably just normally are going to be over 125, but you have clean carotid arteries. So I can't say, you based on velocities, I can't say like you have a stenotic lesion. I don't see anything, everything's nice and clear, but you just have over those velocities. So they realized that these numbers were too low. So there's new recommendations, but they haven't been implemented yet. ARDMS hasn't picked them up yet. So as of right now, these are the numbers that you guys have to memorize and to be familiar with.
Could Sunira be over 182 or no?
She might be, right? I don't remember what her velocities were.
Okay.
I remember being in school, like, when I was 20, whatever. And yeah, I was like 135 and everyone's like, oh my God. Like, I don't know. That's when I was running and I was actually active.
Maybe I'm thinking of the wrong vessel, but I could have sworn Andrew was at like 200 somewhere. I don't know.
Probably. I believe
But
it.
but am I right in my view on this? The story that I told you is the opposite of what you're talking about, that she detected like a 70 or the ICA to CCA ratio is what I think she did, and it indicated that there was less than 70% occlusion, right? 50 to 69. It was like estimated 68 or something, but the diameter was, what am I trying to say? The decrease in diameter in that formula indicated a greater than 70% occlusion, or 75% really. So
Yeah.
So that's the opposite of what you're talking about with of Sydney's question. Sometimes the velocities can be lower, but the diameter of the vessel indicates, okay.
Indicates more severe disease.
Right.
And on the other side of that, if you're young and athletic and you have fast, strong heart, you can have velocities that are over these criteria, but no plaque at all. So in that case, you just document your report, the velocities are this, but no obvious plaque visualized, within patient's internal carotid artery. So Rochelle, I was just saying, this is the chart that you guys kind of have to learn to memorize. This is the one that's going to be questioned of you guys on the boards. And these velocity criteria. So we're talking about ICA stenosis and blockages. So we only ever categorized and ICA stenosis. Like we don't do this for the CCA. We don't do this for ECA. We don't do this for vertebral. We just want to determine the degree of narrowing for the internal carotid arteries. And it's based primarily on your peak systolic velocities, but we do have some other indicators that, kind of go along with that as well, that are supportive data to indicate these particular degree of narrowing. So I was just saying,
My Zoom crashed.
no, it's okay. So we can only ever say a carotid artery is normal if there's no plaque at all. So if it's completely clean, if there's nothing in it, then we can say it's normal. But as soon as you see a little speck of plaque, even like if it's 1-2%, little something, we can't say it's normal. We have to say less than 50%. I know it sounds horrible, like to write that in the guy's preliminary report when it's pretty much essentially clean, but you have to mention that it's just less than 50% at that point. Next, so normal and less than 50% are considered on what are called non-hemodynamically significant. So once you get up to that 50 to 69 and greater than 70, those stenotic lesions are considered hemodynamically significant stenotic lesions. So they're hemodynamically significant because they are starting to limit the blood flow that's getting up to the brain. The velocities are starting to increase at that point. So you just have to be familiar just with your ranges. So 50 to 69 have a peak systolic velocity of 125 to 230. greater
Mm.
than 70 peak systolic velocity, greater than 230. And then just your end diastolic velocities. So normal less than 50, your end diastolic velocity should be less than 40. And then
Mhm.
40 to 100 for 50 to 69, and then greater than 100 for greater than 70. So
Okay.
I think it's your final. This chart is going to be on there, and you're going to have to fill in these numbers. So your ICA, CCA ratio, your end diastolic, and your peak systolic velocities.
And was that other chart, because I didn't see this other chart, looks like you got through a lot of
No,
slides.
I skipped ahead. No, some of
Oh,
these
did
charts,
you?
no, you don't need to know this
Okay.
Washington criteria now. These are just some other methods that are out there. But this
Mhm.
is the one that's widely recognized and widely used, this consensus criteria.
Okay,
I was just meant, yeah. Yeah, this is the one
okay,
that
so
I want
don't
you guys-
worry about
yeah,
that
don't worry about all
other
all those
criteria.
other ones. No.
Okay.
Yeah.
Okay, okay. Thank you.
Um, So it's recommended with that consensus criteria not to subcategorize stenosis less than 50%. So don't try and like estimate, 10%, 10 to 15, 15 to 20, just say less than 50 in your report.
Why is that exactly? Like, why don't they categorize it like that other chart, 0, 1 to 15, 16 to 49? Doesn't that make it a little more accurate, or?
I asked Kirsten the same thing. All she said was, well, those are the guidelines. Yeah,
Not a question.
that's
Just
it.
do it.
Really.
It's just one of those things that I need to get over, and it is what it is.
It is what it is. Yeah.
Okay, all right.
Um,
Well, quick, I really didn't think to follow up with Kirsten because it was bugging me too, Rochelle, and I'm like, well, if it is really, really small, then would you communicate that like in a note to the doctor so they could assuage the patient's concern, or is the patient just going to be like, oh, well, the doctor's telling me it's not that bad, so I'm okay? Most people are like that, I would imagine, or
Yeah.
not when it comes to the carotid.
yeah. I mean, yeah, if there's just like minimal plaque, yeah, the doctors be like, oh, there's just a little plaque here, but nothing significant.
Yeah, I don't even think. I mean, most of the people you're seeing in a vascular lab are probably, on the higher end of less than 50%, most likely. But I mean, I don't remember if she wrote. I wanted to be like, well, why don't you just write a note that it's not that bad on the bottom?
Not that bad.
I don't think, or something along the lines of it's not.
You can
49.
kind of,
I don't
like,
remember.
no, you did fine. Don't worry about it. You're okay. Doctor's gonna look at all these images. You'll get the report soon. So, I mean, you're not technically giving them results. Like, yeah, don't worry about it. You're fine. Like if in your heart of hearts, it's just a little minimal plaque. You can tell them, no, you did fine. You did all right. Doctor's gonna look at all these pictures. You'll get results soon. All right, good. A doctor is not going to alarm them either. Like, oh my God, you got plaque. It's 1% blocked. Like,
Yeah. But I don't know, Dan and guys, I'm looking forward to next semester having a little more time, because just even an extra, basically 2 weeks at this vascular lab, like still just basically observing, but I feel a lot more comfortable with what I'm seeing, and then going over all this, it really starts to make sense.
Yeah, summer session, it all comes together. like for you guys, like when you start, you've learned the material, you've seen it a lot now, and then you're starting to scan more and more. Yeah, summer sessions kind of when it all like, all right, I got this. And then the last year you'll be doing full echoes, hopefully. Full exams. Yep.
I don't know. I've already experienced, you had the older man that was extremely dressed up and looked really nice, but smelled so horribly of cologne. Nice guy. And then you have the older lady that just smells. And then you've got the other guy that's, from India. So then you've got, not being, judgmental or whatever, but it just, the whole room smells of curry. So it's just, you're going to have interesting experiences no matter where you work. I mean, the lab has that component, and then the hospital. I don't know. I mean, potential sonographers want to factor that into where they want to work. For me anyway, I don't know. All right, I'm done.
Take whatever job you can get. So this was just showing some images for a focal aliasing. And I'm sorry. With a focal area of CCA stenosis. So in this case, they actually measure velocities of 722, which is crazy fast. So here we're just imaging patients' internal carotid artery, so distal CCA bulb, and then proximal ICA. So with that, you see some area that looks like potential turbulent flow. So you're going to want to interrogate that area where you see the aliasing. In this case, they utilize the power Doppler because that carotid artery looked like it could potentially be occluded, but there's still a little bit of flow getting through. So you see a lot of significant plaque within the actual vessel itself.
Do you like that image, or would you rather us kind of?
I would steer the box, like just
Steer the
like the same
box.
with your color Doppler.
Yeah.
Like always have an angle. I don't even like the one before it, like straight up and down like that. Steer angle. You're gonna get better filling. You're gonna get better everything. To be honest, it's all about steering and angling.
So what? Why is this such a refrain, Dan? Was this purposeful? Was it Lily who made
It's
these,
old.
or is it just
I don't know. I think
whatever
they're just old.
the best she could find, basically?
I'm going to I'm gonna have to update all our slides at some point.
But what do you mean it's old? In the
These
sense
are the
that-
PowerPoints Lily's probably used for years and years and years. Like when she taught vascular.
Okay.
Yeah, she's so this was um with moderate ICA stenosis. So you can see the bulb, we've got some calcified plaque. It looks like there's some shadowing going on in the bulb, some posterior shadowing. We can see some echogenic calcified plaque. With color on, we see what looks like a very significant narrowing of that vessel. So with the moderate amount of soft plaque and calcified plaque. So this is just a greater degree of stenosis. And when we measured, they got velocities 139 and diastolic 60 and a ratio of 2.4. So all those factors point to a 50 to 69% stenosis.
So if somebody had okay, 662 or 700 something velocity. Is that the
That's
case
really
where
high. Yeah, that's high.
if that hadn't been noted before, like I'll go back to Kirsten, was like, if I find something that's really bad, then I'm not going to let you leave, and we're going to let the doctor know or something. So in that case, if it hadn't been noted before, then this is maybe that case, or there's
Yeah,
not
if it
much they
hasn't,
could do immediately, but
yeah, if they haven't noticed it before, yeah. I mean, at that point, yeah, you let the doctors know if you have a significant stenotic lesion, yeah. And then it's the doctors determine, all right, let him go home, we'll be in contact with him. So any stat findings, depending on where you are, greater than 50% could be considered a stat finding. Could be, some places might consider greater than 70% a stat finding. So any stat findings that you encounter while you're doing scans, particularly on outpatients, you need to contact the patient's ordering physician, either your office or you personally, to see what they want you to do. Whether you want that person to go right to the emergency room, or it's okay for them to leave and go home. So you kind of have to get that okay before you let those patients leave.
got it.
So for me, I work primarily in hospitals. I mean, I was floated to outpatient offices as well, but I was primarily in the hospital. So I was never really too big of an issue, with us. We just had to contact, whoever's taking care of that patient within the hospital to report stat findings when we encountered them in the vascular lab. So patients that were positive for DVT, we had to call the floor and get a hold of their doctor, NP or PA to let them know. And then they would typically, order the heparin or anticoagulation medications to get them started on that. And so things were ready for them when they got back to the floor. So this is another example of a severe ICA stenosis. So distal CCA was 70.5. On the same side, the ICA color shows a dense calcified plaque with some shadowing. So here is the vessel, and we're getting all this calcified plaque. We can't even really see what's going on in this segment of the vessel because of that calcified plaque. Ultrasound's not penetrating through. All we see is the color flow on the other side of that plaque coming out of it. And when we Doppler that, we get velocities of 581. So that would indicate, somewhere in here, we have a very high grade stenosis within that area of dense calcified plaque. So even though we can't, specifically visualize that narrowing or that stenotic lesion, we Doppler on the other side of that calcified plaque and we see very fast velocities. That's enough to say, like, all right, we got a high grade stenosis going on in here. Here's another severe stenosis. We got the CCA, and then all of a sudden it narrows and tapers, and we got this turbulent jet of aliasing coming through. Here they Dopplered. CCA was 40 with the end diastolic 10. So we have very slow velocities entering into this stenotic lesion. So this is a good example. Maybe this patient has a low EF or a weak heart. And then when we Dopplered within that stenotic lesion, they got 178. Here they were able to get 220. So they found a higher velocity eventually. With some post-stenotic turbulence afterwards. So with those higher velocities, when they put it into that ratio, you're getting ratios of 5.4. So even though this doesn't fall into that greater than 70% in terms of that peak systolic velocity, the end diastolic velocity is over 100. So that indicates greater than 70%. And that ratio is over 4, indicating greater than 70%. So something using those other alternate criteria, you'd probably say that, this is a greater than 70% stenotic lesion. Just because of that velocity ratio going from 40 up to, they were able to eventually get 220 is a very big jump. So what's causing that big jump is that stenotic lesion. It's causing, you want to see how fast that velocity is accelerating from here to here. So use that ratio to see how fast it's accelerating to determine that degree of stenosis. Um, so here we had a bunch of severe irregularities. So it looks like there's multiple stenotic lesions or areas of narrowing through here. So this one would be more difficult to kind of walk yourself through Doppler, trying to find those maximum velocities. But this also would be considered greater than 70%. Your peak systolic velocity, they got 369, 128 for end diastolic, ratio 6.15. So in this case, this patient had an near occlusion for their ICA. B is just showing the peak systolic and then diastolic velocities for the CCA. Within that stenotic lesion, they got 204. And then they were able to Doppler a little bit distal, and they got a tartarus parvis waveform. So there's a little bit of flow still getting through with a tartarus parvis low velocity waveform afterwards. So with carotid occlusion, we want to demonstrate absent flow signals. So you want to demonstrate absent flow using your color, your power Doppler, as well as your spectral Doppler. So you want to utilize all three to prove to the doctor that, yes, this carotid artery is completely occluded. You might be able to demonstrate that high resistance systolic thumping of the waveform with absent or even reverse diastolic flow just before that's occlusion. You might notice a drumbeat sound of the lesion and the vessel wall co-vibrating. There might be decreased arterial wall pulsations compared to the other side. We might see delayed systolic flow acceleration, maybe blunting of our middle cerebral waveform, or evidence of flow diversion or branching of these vessels. We might see collateralization of flow in our ophthalmic artery, our anterior communicating arteries, or even our posterior communicating arteries. So if we're doing a transcranial Doppler and the patient has a carotid occlusion, we might see some other things. So with the CCA occlusion, so in this case, the patient's CCA is occluded, common carotid is occluded, but when we get up to our bifurcation, we see flow identified in the patient's ICA, and that flow is coming from the ECA. So we're getting retrograde flow actually in our ECA, coming back around and then supplying our ICA. So this can happen when we have CCA occlusion and our bifurcation is still okay. So this is a right ICA occlusion, showing no flow present. Then we saw retrograde flow in that ECA. It was indicated by blue. When they Dopplered that ECA, it was lower resistant with retrograde flow. So ECA is now supplying blood flow for that ICA. So it's taking on those ICA waveform characteristics. So the only time we'll ever see ECA flow reversal is to feed that ICA when we have a CCA occlusion. So these are just kind of specific criteria or specific situation where we would see ECA flow reversal. So we would see ECA flow reversal with CCA occlusion, and the ICA is still open. So we see flow reversal in that ECA to feed the ICA. The ECA becomes lower resistance. We can have ICA occlusion. So here we can see CCA bulb and then the ICA filled with some echogenic material or intraluminal echoes. No flow going through that. So they lowered their Doppler scale down nice to 6.7. So that's good. Again, always maybe put your power Doppler on to just verify that. With color, you could see the CCA bulb and then ECA and then the ICA being completely occluded, filled with intraluminal echoes. You can potentially have acute thromboembolic acute clots basically in the patient's ICA that could lead to occlusion. So maybe-
Sorry, can you go back to that last image. So that would be considered an ICA occlusion and not an ECA occlusion? The
Uh,
top coat, because like where I guess like where I'm seeing it is that,
Yeah, so this is common carotid bulb, and then this is the ECA still open, and then the ICA. is this
sorry,
one.
yeah, I was looking at something different. Sorry,
Yeah.
just kidding. Keep
No,
going.
that's okay.
Wait, and Dan.
Yep.
Why is my video not working? Could you go back one more to the CCA inclusion slide?
Yep. So
It's
your
not making.
patient's common carotid artery is blocked. That bifurcation is still open, so there's no plaque in there. There's no blockage. There's no, I want to say like maybe a thrombus or something, like nothing is blocking that bifurcation. So that's okay. That's still open.
Yeah.
What's going to happen is that the patient's external carotid artery is going to reverse, and then blood flow is going to come reverse up that ECA into that bulb and bifurcation area, and then go up the ICA. So it's going to come down the ECA, go into that bifurcation area, and then up the ICA to bring blood flow to the brain. So
Okay, so
that'll only happen with a CCA occlusion. So we needed some sort of CCA occlusion. So maybe it's proximal, maybe it's down by the origin of the CCA that's occluded. So no blood flow is getting up that carotid artery. But the brain still needs some blood, so it's going to steal it from the ECA. You'll have retrograde flow in that ECA, and it's going to siphon that blood into the ICA. So it's going to come back up the ECA, around, and then into the ICA at that bifurcation. So kind of like picture that tuning fork, like it's going
Yeah.
to come up the ECA into that bifurcation, then up the ICA and up to the brain.
well, where's the ECA getting blood from? If the
Where's it getting blood flow? That's a good question. It's through some of those anastomotic connections too that it has. From the circle of Willis.
okay,
We'll get through the ophthalmic artery, like we'll get retrograde flow coming from the left side. So if it's the patient's right side that's blocked, left side will open up. We'll come across that anterior communicating artery to the other side, and then through their ophthalmic artery, we have connections with the ECA. So we have collateral channels.
okay, so the right vertebral could even have connections that could.
Yeah,
Blood
so
could
we
come
get
back
the
through.
right vertebral, if the CCA is occluded, yeah, right vertebral, if it's the right side, would open up, we'd have higher velocity flow. We can get it from the posterior circulation as well.
Okay,
I mean, that'll
okay,
help. So this was more ICA occlusion. Again, utilize your power Doppler to confirm occlusion. So you're going to do power Doppler. You're also going to do your spectral Doppler. This was a distal ICA occlusion. Here, when they Dopplered, they just were getting some small systolic thumping. Absent diastolic flow. So this was a good example too with the ICA occlusion. So when they Dopplered the patient's distal CCA, this isn't a normal waveform. We have no diastolic flow. It's a very high resistance, so we shouldn't have this high resistant flow. And then when we looked at the other side, there may be increased low resistant flow in ECA as collaterals attempt to increase blood flow on the same side. So this is also sometimes referred to as internalization of the ECA. So when our RCA is occluded, we have those collateral pathways, those collateral channels, the connections between the ICA and the ECA higher up. Those branches of the ECA connecting with the ophthalmic artery of the ICA. So our external carotid artery can become what's called internalized. So it takes on the characteristics now of the internal carotid artery. So that can happen when we have an ICA occlusion. So the ECA on the same side can sometimes become internalized. The opposite side will have, increased flow. So these are all just, some of the compensatory mechanisms that are going to happen. One side's blocked, one side has disease, the other side's going to try and compensate. So we'll see increased flow on the other side and the ICA, CCA, vertebral on the other side. If our CCA or ICA is blocked on this side, the vertebral artery on this side is going to have increased flow to try and, compensate. So the body is going to, do all these things to try, and compensate for that disease or that blockage to bring blood flow to the brain. So these are just showing some more ICA occlusions. No flow present in transverse and longitudinal. Doppler waveforms demonstrate the absence of flow. So all we're getting are just these little, pre-occlusive systolic blips. So we just also want to be aware that we don't do a false positive diagnosis of occlusion. We want to make sure it truly is occluded versus a near occlusion. The artery might be obscured by acoustic shadowing, might make it difficult, and might have poor image quality, and Doppler signals are very weak. So that's why we utilize this power Doppler to pick up slow flow. We're going to use color with a low PRF, a low wall filter setting, raise up our color gain. So we're going to maximize our images, and always use spectral Doppler as well to prove that it is truly occluded. So any sonographer should really search diligently for a residual lumen in cases of near occlusion. Because again, if the vessel is completely occluded and there's no flow, there's nothing that a vascular surgeon is able to do at that point. But if there is still a small residual lumen, no matter how small it is, we could still potentially, they could still potentially do an endarterectomy, or potentially, try and do an atherectomy, or I don't want to say stent at that point, but they could potentially be a candidate for trying to open up that vessel still.
So what exactly does residual lumen mean? What
Residual lumen, so that
Yeah.
there's still a little bit of there's still a small channel within that vessel that is patent, that there's blood flow getting through. So residual
Okay.
lumen refers to the inner lumen is the inside of the vessel. So the
Right.
vessel lumen is the area inside of the vessel where blood flow is getting through. So if there's a residual lumen, there's still like an area that's still patent, that there's still some flow getting through. So you want to search, for that residual lumen, that there is still flow getting through somewhere.
Okay.
Um, so these are just showing some more pictures. So here in sagittal, it's kind of hard for us to see what's going on because of that calcified plaque. But the segment that we're able to Doppler, that's outside of that stenotic lesion with the plaque, demonstrates tardish parvis waveforms that are consistent with some sort of severe inflow abnormalities. So in cases like this, when we can't really see what's going on within that stenotic lesion and determine the degree of narrowing, but we see, post-stenotic tardish parvis waveforms, we know that there's some sort of severe stenosis going on in there. We would potentially recommend them for CTA to see exactly what's going on. So unfortunately, ultrasound is great. We do our exam, but sometimes there are limitations due to this shadowing of calcified plaque that doesn't allow us to visualize accurately or adequately these stenotic lesions. We do recommend them for other examinations. So that was one of like our kind of default lines that we had in our preliminary reports, like other imaging recommended, So this was a 79-year-old male with previous stroke, left hemispheric stroke. Left ICA origin shows a very narrowing stream of flow. With the peak systolic velocity of 53, MR confirms presence of typical focal nearly occlusive lesion. Distal ICA is much smaller than the contralateral ICA and is smaller than the ipsilateral ECA. So it's these little arrows here.
Or sorry, could you go back to that slide and leave that on there real quick? Because okay, I couldn't see the arrows on my wonderful
These little
printout here.
arrows here showing ICA is very narrow. So you can barely even make out the patient's ICA kind of going up. Looks like a bag of
So
worms.
that sort of
CCA,
where that
ECA.
vessel
get all
disappears
these.
at the arrows there. Okay.
Yep.
All right. All this newfangled technology. Thanks.
It's just some more pictures just showing, stenotic lesions. So ECA stenosis. So we can have narrowing and stenotic lesions in our ECA. We don't break them down in terms of like degree of stenosis or degree of blockage like we do with the ICA. We just demonstrate, the ECA demonstrates elevated velocities. That's the line that I always put in my reports. So here you could see, very fast velocities within these patients' ECA 235. So you guys will start, as you start scanning, you'll realize, what would be considered elevated velocities versus normal. You'll be able to see, areas of stenotic lesions or areas of plaque. You'll see turbulent flow. ECA typically is going to be that, again, that very sharp, very sharp waveform. So this is a patient that had an innominate artery stenosis or brachiocephalic artery stenosis. So in this case, their right vertebral demonstrated flow reversal. Their right ICA have a subtle mid-systolic deceleration and abundant diastolic flow. So these waveforms in the ICA and the CCA, they're not normal looking. They look more tardus. They're definitely tardus parvis waveforms. So we know that there's got to be some sort of proximal stenotic lesion. So in this case, there was a patient that had an innominate artery stenosis. So we saw retrograde flow in the vertebrals. We got tardus parvis waveforms in the ICA and the ECA.
So in that previous slide, Dan, the ICA and the ECA are doing the best they can with the blood flow they're getting from the vertebrals.
Yep, they're trying the best. I mean, the velocities are very slow. So I mean, this is like basically 30 centimeters per second, 17
Okay.
centimeters per second. But yeah, that's not a normal looking ICA
Okay.
waveform, particularly with the ECA. That's definitely abnormal.
I have a horrible vascular joke that popped into my head, and you're the movie man. You've seen the Monty Python movies?
Sure. Which one?
Anybody else? Yeah, where the knight is getting his extremities chopped off. Which one is this?
Yeah, the
The Holy Grail.
Holy Grail. Yeah.
And he's like, I'm not dead yet. And that's sort of what's going on here. It's like the ICA and ECA are saying, I'm not dead yet. But this is
Kinda.
not good, right?
I like when he's just the head. Come back here, I'll gnaw on your ankles. He still wants to fight him.
But an innominate artery stenosis is not a good thing.
Yeah, so they would have to go in and fix this. So I mean,
Right.
that's going to affect your pressures in your arm. Your arm might be weak. Might get a lot of cramping in your arms. I mean, there's going to be other things too. So
And then you fix this, and then ideally you could just
everything should go back to normal. Yeah.
back to normal. Okay.
So stent
Right.
open that stenosis, open up that vessel, and this everything should go back to normal. Yep.
The patient will say, I'm all better now. I can feel the left side of my body.
I know,
Right.
right? So this was a 68-year-old male who presented with the right cervical bruit. Right ICA had very fast velocities, almost 500. So that's greater than 70% stenosis. Based on the velocity criteria, greater than 70%. But we also demonstrated in this case elevated velocities in the CCA and ICA. Left CCA was 132, left ICA 172. But there was no visualized plaque within those vessels, just elevated velocities, but that's due to that compensatory flow. So we had a severe stenotic lesion on the right side, body's compensating for that by increasing flow on the left side. So that's just something, you document the velocities, but you could say in your report, no obvious signs of plaque noted within left ICA. And no evidence of plaque seen in left internal carotid artery.
So when we're saying cervical, what are we referring to? A cervical bruit?
In the neck, cervical. So this is your cervical spine, like your cervical vertebrae. So cervical is in your neck.
Okay.
Cervical bruit. So they heard a bruit in their neck.
Not worried about saying where this bruit is, or it's represented on there. This is just a general description of what this
Yeah,
is.
just a general description. Yeah.
Okay.
So here, which side is abnormal? So this was a 78-year-old male with the history of a TIA. The right CCA showed tardus parvis waveforms, proximal ICA dampened waveforms, vertebral artery biphasic waveforms. The left ICA had normal flow. So in this case, vertebral that's that crouching bunny. So this is considered bidirectional. So we got a portion of that waveform that's actually below that baseline here. We're not seeing it. For me, it's like kind of cutting off a little bit. But this is considered retrograde flow, subclavian steel. Our CCA waveforms are abnormal as well. So we got these tardus parvis waveforms in our CCA. Slow flow within that ICA. So this would probably indicate an innominate artery stenosis or occlusion. In this case, here's that aortic arch, and then your branches of your aortic arch. So there's that first branch, and then this patient's innominate artery had a stenotic lesion where it was very narrow. So in this case, this was a 73-year-old woman who suffered a right hemispheric stroke. Waveforms were obtained after the bifurcation. And they were trying to figure out which one is ECA and which one is ICA. Any ideas? They look pretty similar.
The one on the bottom is a branch, right?
Yeah. So they were Dopplering. They were thinking that this was the bifurcation. So they thought maybe this one was ICA and this one was ECA and this was the bifurcation. But actuality, this was the ECA and this was just a branch off that ECA. So they were Dopplering, one of the branches of the ECA, and the ICA is actually completely occluded. So when they did the angio CCA coming up, so here's your ECA, nice and large. You see the branches coming off your ECA, and that ICA is completely occluded now. So they didn't even see the ICA in that case.
Andrew, you're so smart. You got it.
The gave it away was obtained after bifurcation. It looked like the bifurcation.
Does it cut it off for you?
Oh, that's better.
Yeah, it's better. Yeah, it was
What did
cutting
you
it off.
do?
I don't know. But I like that better. Now I can see.
Yeah, I thought I was
55-year-old
hallucinating
male.
before
I know.
with the my computer's dying here. Don't die. With that one waveform, it was you said it looked more like the ICA, and didn't look like it. And I maximized the screen or looked at my slideshow. I'm like, oh, okay, that's what it's supposed to look like. All right.
So this is something that, you guys might be able to encounter or be able to figure it out. So the DMS students, when they're doing carotid arteries, this probably wouldn't even cross their mind. But looking at all these waveforms, they're all kind of tardus parvis. So they all kind of have a delayed upstroke with them. Particularly the ICAs and the vertebrals, you can see that. And the ICA, particularly on this left ICA, you can see it has a very delayed upstroke. So this is a patient that has a severe aortic stenosis. So the aortic valve is what's creating that stenotic lesion and causing, these abnormal Doppler waveforms in this patient where everything looks, tartarus parvis. So if you see it in your ICAs, your vertebrals, your CCAs on both sides bilaterally, could be that heart, the aortic valve that's causing that stenotic lesion. Nope.
You said the aortic valve?
Yeah, so the
is what's
aortic, it's the
causing
aortic
stenotic
valve.
pain?
Yep, so this patient has a highly stenotic aortic valve.
Mhm.
So because that aortic valve is so stenotic, it's affecting
Yeah.
your waveforms in your carotid arteries.
So all those vessels are receiving blood from collaterals.
No, they're receiving, they're getting blood flow. Like blood flow is still coming out of the heart. It's just
Okay.
it's reduced. It's dampened. You have tartarus parvis waveforms. So you have post-stenotic tartarus parvis waveforms.
Okay, so this man is having all sorts of symptoms at this point of aortic stenosis.
Probably, yeah. Not only how it's affecting his heart, yeah. So maybe it's all
So
backing
are
up. Maybe he's got pulmonary hypertension. Maybe he's got a hypertrophic left ventricle. Maybe that left ventricle is starting to dilate. Maybe he's got AFib now. Maybe that left atria is
Okay.
all dilated. Who knows?
vascular and echo are crossing over.
Yeah.
Right. You don't look thrilled, Rochelle. No.
What?
I said you don't look thrilled. I was making a connection between where we're at in echo and vascular and how the symptoms of aortic stenosis are related to, stenotic lesions and the aortic
Oh,
valve.
I wasn't even paying attention. I'm so sorry.
Okay.
So sorry.
So in this case, patient presented with syncope, left ICA demonstrates an area of aeolocene consistent with increased velocities. Distal CCA 79, mid ICA 158. So even though, we didn't see any luminal narrowing, there's no plaque or significant luminal narrowness seen in this region of the vessel. That ratio still is 2-to-1. So with the diagnosis, you still kind of have to call it, like you don't visualize any real narrowing of that vessel.
So there'd be another reason for his syncope, for his fainting then, other than
Could
this.
be, yeah.
But it could still be qualified as less than 50%, but could present with, he could still cause him to present with syncope.
Syncope? Not likely.
No.
Yeah,
Okay.
yeah, not likely.
So hence, that sort of gives a little more, I don't want to say legitimacy to the standards of the consensus criteria of ICA stenosis, but that gives you a little indication, like Rochelle, where you were saying, well, why is less than 50%, not, why is it all lumped together? Well, because it wouldn't be symptomatic until you get over 50. Is that part of the reasoning
Usually,
behind this
yes,
criteria?
usually that they won't present with symptoms unless you get over 50.
Okay.
So this was a 70-year-old who presents with right with the right CVA, cerebrovascular accident. No focal stenosis is seen in the left CCA or ICA, and there's no evidence of significant atherosclerotic plaque. A shows the left ICA. Doppler of the left CCA. And then Doppler of the waveform for the left ICA. So this is very low velocity now. And it looks fairly high resistance compared to what we'd expect the ICA to look like. So this was probably indicating a lesion that's further upstream that maybe we're not seeing. So maybe intracranial ICA is occluded or blocked. Maybe we have some sort of stenotic lesion higher up in that ICA that we're not seeing. So this indicates a more distal stenotic lesion. So these are a little high resistant for that CCA. Not terrible, but there's still some diastolic flow. But when we get into ICA, this doesn't look like our normal ICA waveform. So this, indicates a dampened waveform proximal to stenosis.
Yeah, we definitely had this in our in vascular with the woman who was blind, I believe. So she didn't have any stenosis, but she had this waveform, and it indicated, like you said, like it says here, a lesion further up.
All right, so this is kind of like something that you guys just need to remember, kind of wrap your heads around. So low velocity, low resistant flow patterns, represent dampened tardius parvis waveforms. So when you see low velocity, low resistant tardius parvis waveforms, this indicates disease that is proximal. So it's before where you're Dopplering. It's proximal to wherever you're Dopplering. So if you're in your proximal ICA and you see this, the disease has to be in CCA or, maybe innominate aortic arch if it's the left side. So tardius parvis waveforms indicate proximal disease. Low velocity, high resistant waveforms indicate distal lesions. So disease that's further upstream that we're not seeing. Low velocity, high resistant flow indicates distal lesions. Tardius parvis, low velocity, low resistant flow indicates proximal disease. So the boards are just gonna love to ask you questions. They'll show you some waveforms, demonstrates, low velocity, tardius parvis waveforms seen in mid CCA. Where's potentially the disease? Could be proximal CCA. Could be, in that case, innominate on the right side. Could be aortic arch. If it's bilateral, it could be the aortic valve, aortic stenosis. And again, if you see low velocity, high resistant flow now, this indicates a more distal lesion. So if you see low velocity, high resistant flow in the CCA, could be ICA occlusion. If you see it in the ICA, like proximal and mid ICA, it could be a distal ICA occlusion. It could be occlusion, intracranial. Let's see. High velocity, not consistent with color flow image. So a patient had a carotid endarterectomy 8 years ago. His left CCA is occluded. His right ICA CCA has a ratio of 2.1. Right CCA velocity are high to compensate for that occluded left CCA. So they estimated approximately 50% right ICA stenosis with exaggerated flow due to that collateralization. So even though his ICA velocities were 257 and diastolic 115, they estimated it as around a 50% stenosis because those velocities were higher due to compensatory mechanisms. So that right side was trying to compensate for that occluded left side, so it had elevated velocities to start. So they used that velocity ratio in this case, going from 121 to 257. It's a little more than a doubling. So they put it in that 50 to 69% range. All right, let's look at our waveforms now. Comparing our left CCA versus right CCA. So which one's normal, which one's abnormal, left or right for CCA?
Is the right one normal?
Yes, yeah, right one's normal. So we got the characteristics of our ECA and our ICA. I could see a deep dicrotic notch. We've got some diastolic flow, comes to a sharper point. So this for a left CCA, that doesn't look, that looks more like an ICA waveform, if anything. So it's got delayed upstroke. So it's got this tardus parvis looking waveform. The velocities are, it's lower velocity, low resistant. So this is a tardus parvis waveform. So this is telling me that there's some sort of proximal occlusion or some sort of proximal disease going on. So I see it in the left CCA. I see it in the left ICA as well, compared left to right. Got low velocity, low resistant, tardus parvis waveform, so delayed upstroke. This looks like a nice, healthy right ICA waveform. And then right ECA, that looks normal as well. That looks like a nice, healthy right ECA waveform. So even with the left ECA, we're seeing low resistance, low velocity flow. So with this could be a high-grade proximal left CCA stenosis. So depending on where this CCA waveform was taken, if it was mid-segment or distal segment, that stenotic lesion has to be maybe right at the origin of that left CCA, maybe right along that aortic arch. So this would be a proximal non-visualized segment of that proximal left CCA that's causing this. Ooh, excuse me. How much more do we got with this? Almost done. Let's see if there are any more. So this was just another example of using your velocity ratio. So just based on the velocities alone, it would put it at a 50 to 69% stenosis. But if you use your velocity ratios, went from 21 up to 178, that shows a very dramatic increase in velocity. So that indicates that that stenotic lesion, is much more severe than 50 to 69. And just visually looking at it as well. So here's the whole, vessel lumen. You could see that there's just a small area of flow getting through. Excuse me, which indicates, a higher grade stenosis. This was a 58-year-old male who undergone innominate artery stenting 8 months previously. His right CCA and ICA showed biphasic to and fro waveforms indicating innominate artery stenosis. So CCA, we can see bidirectional flow. So we shouldn't get flow, below the baseline. His ICA, same thing. We're seeing some flow, dropping below the baseline, bidirectional flow. If the innominate artery were occluded, flow would be persistently reversed in his carotid arteries. His ECA demonstrated a crouching bunny waveform. Less effect from that, has less effect from that innominate artery occlusion. His vertebral artery should also have biphasic or reverse Doppler waveforms. And the subclavian artery should demonstrate monophasic or dampened waveforms as well. So when we start imaging, try to image that subclavian artery as well. So in this case, this was a right carotid steal caused by this innominate artery occlusion. And then in order to compensate, we had increased flow within the left side as well. So we demonstrated increased flow in that left CCA, more diastolic flow.
Can you go back, Dan, to case, I don't know. You're there already.
So this guy had a central stenotic lesion in his innominate artery.
Uh-huh.
So that affected flow in both the right CCA and the right vertebral. They're not showing the right vertebral, but you saw it in his right ICA. So the whole right carotid artery is affected.
Okay.
So that's how we know it's in the innominate as opposed to just that proximal subclavian artery. So if it's just the vertebral on the right side that's affected, and the right CCA and ICA are fine, then we know that lesion is in that proximal subclavian artery. But if both the CCA and the vertebral are affected, then we know it's an innominate artery stenosis or occlusion.
Okay, when it says right carotid steal, so are we stealing from the left side?
We're stealing from the right carotid artery. So that's when you see that steal, it's that retrograde flow. So we're actually stealing some blood flow from the carotids to try and get out to the extremity.
I don't know what I'm missing.
So we have that central blockage, no blood flow, probably very minimal blood flow is getting out to the arm. So the body is stealing some of that flow from both your vertebral, which is not seen here, as well as your carotid artery. So they refer to this as a carotid steal because that common carotid and your internal carotid artery were demonstrating some retrograde flow. So there's flow that's going in reverse through those arteries.
But you said the innominate was
The innominate is blocked, so the arm has no blood flow on the right side. Your right arm needs blood flow, so it's going to steal some of that from your carotid and your vertebral to try and bring some blood flow to that arm.
okay.
So this was just showing a right ICA occlusion, the left ICA stenosis. Again, no color, no spectral waveform. This was a right ICA occlusion and a left ICA stenosis. So this is now on the patient's left side. So CCA, we could see some intimal thickening and some buildup of some plaque along the intimal walls. At the bulb, we get a big area of calcification and shadowing. Another angle on that bulb, you can kind of really appreciate, all that calcified plaque that's within this bulb. So with color, we can't really see what's going on within that bulb, but we get good color on the other side of that atherosclerotic plaque, that calcified plaque. So you would Doppler, on this side to see if you get any elevated velocities or any evidence of tartarus parvus waveforms. Try and give you an idea what's going on, in that area. So these are patients that, you may want to recommend for additional testing to see exactly what's going on, particularly if your waveforms are telling you, there's a stenotic lesion in there. So if you're getting tartarus parvus waveforms, you'll want to recommend them going for some sort of CTA to see what's going on in that area where you can't see. So this is a patient who had a left ICA stent. So in here, you can see the circular formation of that stent. You might be able to see the striations as well. So his right ICA is occluded. He's got a stent on the left side. Put a stent in that left ICA, and they're just showing the waveforms. So those are good. Those are, decent looking waveforms for a patient who's had a stent. All right, so just some general limitations. Body habitus can play a big factor. A patient has a large muscular neck. Maybe they have high bifurcation, so we can't see a significant segment of that ICA. Vessels might be deep. They might be very tortuous. There might be tumors. Maybe there's a carotid body tumor. Maybe the patient has an enlarged thyroid gland that has a multinodular goiter that might displace the vessels. If there's any sort of dressings from line placement, skin staple sutures, scars. Patient movement. So unfortunately, if patients are trying to talk to you during a carotid exam, that's not going to bode well for you. It's going to make it very challenging. So you got to just remind them to be quiet. Rapid respiration. Sometimes heavy breathing, rapid breathing will cause those vessels to kind of move up and down on you and make it really hard to try and Doppler. You may overestimate the disease. So that's a potential pitfall. Artifact might be mistaken for plaque. You might have increased flow velocities due to increased cardiac output. Just remember vessel tortuosity too. Velocities will increase going around curves. There might be compensatory flow. So one side might have disease and the other side might be compensating and have increased flow. We might have inappropriate angles as well. We may also underestimate disease. So some of these soft plaques have very low echo levels. So they're very anechoic or very hypoechoic. So we might miss some of those soft plaques. We might miss increased velocities due to long segments of plaque. We might have long areas of shadowing where we can't see some of these plaques. Might have inappropriate angles as well. There might also be limited vertebral artery assessment. So we don't typically image the entire vertebral arteries. We also can't image, between those vertebral columns as well. So it's also not a reliable in detecting lower level carotid stenoses. So it's reliable when we get over 50% stenosis. Determining the degree of stenosis when it's less than 50% is not as reliable. So that's why we just say less than 50% stenosis.
And we can't use that word stenosis as this morning. It's just not.
So estimate stenosis based on that consensus committee velocity criteria. So in this case, proximal ICA was 289, end diastolic was 63. ICA CCA ratio was 3.3. So if we had to use that consensus criteria, we might lean more towards that 50 to 69 because this one falls under the 50 to 69. This also falls under 50 to 69, even though our peak systolic is, greater than. So you might be kind of right on that cusp. This one's obviously greater than 70%. That's really super fast.
What if you are on the cusp? Would you still, alert a doctor? Like I'm saying, if it's greater than 65%, or do you let it go until it reaches that 70% mark?
I would notify the doctor of the velocities that you got and kind of leave it up to
Okay.
them. At least you've covered yourself. I mean, that's also important thing for you guys coming out. Always cover yourself. Like if you're ever in doubt,
Mhm.
let them know and let them decide. Like, hey, this is what I'm measuring. Kind of borderline. What do you guys want to do, or how do you want to handle it? At least, and then you document in your preliminary report. Notified Dr. So and so at blah 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 of preliminary results.
Mhm.
So at least it's documented in the patient's chart. You told the doctor, this is when you told the doctor, so at least you've covered yourself. You've done your part.
At what point would you say that we should do that at? Like 60 or more or closer to like 65? Like rather be safe than sorry.
Well, if you trust the people you work with, you can ask them. They're like, hey, you think I should call this in? And they'd be like, oh, yeah, might as well. I mean, it never hurts to call it in. I mean, they'll tell you,
Yeah.
they'll be like, why are you telling me this? Like, if they like, I just wanted to tell you, and then you hang up. Like, it's
Just wanted to
okay.
hear your
If you be that annoying tech, it doesn't matter. At least starting out, protect yourself.
Yeah.
And so when it talks about, sorry, Rochelle, were you done? When it says need to evaluate vessel image to be able to estimate better, so is it specifically referring to measuring the diameter and the radius and using the formula to determine percentage stenosis, or no?
Need to evaluate vessel image due to be able to estimate better. Yeah, so
So-
you do a visual estimate. So part of your velocity measurements is also you doing a visual estimate as well. Kind of looking at it, be like, no, that kind of looks pretty blocked. Like, I mean, if your eyes are telling you something that your velocity measurements aren't, so that's it's up to you to also kind of you do a visual estimate. Transverse is your best way to get that real good idea of how stenotic that lesion is. I don't know if you were on yet before, Brian, but I was mentioning in transverse, you get a good view of how wide or how narrow that lumen is in transverse because you could see plaque along all walls of that vessel. So when you're
Yeah, that's
slicing it in sagittal, you might be clipping it a certain way where it looks very mild. In actuality, it's very severe.
yeah, that example that I keep going back to is where she did that, and I said you should put my name on the notes at the bottom because I let you know about that, and she said, "Oh yeah, I'll put and student." From the,
Eventually, some of the reports will say scanned by student, like when you start actually doing these exams. All right, carotid endarterectomy, surveillance and intervention. So again, that carotid endarterectomy is that surgical removal of atherosclerotic material and the intimal lining from the artery. So when we scan these patients after they've had an endarterectomy, we might notice absence of that intimal medial stripe during that early postoperative period. We might actually see sutures on the carotid artery if they had to sew in, particularly if they had to use a patch. With that carotid endarterectomy, the main thing that we worry about now is that neointimal hyperplasia. So that's that thickening of the wall as a result of that trauma to the vessel of us doing that endarterectomy. And that's something that appears in the months to years after post-surgery. So it's not the immediate postoperative period. It's in that kind of mid-range postoperative period that we see this neointimal hyperplasia, or that thickening. So that neointimal hyperplasia can cause a stenotic lesion potentially in that patient's carotids post-endarterectomy. So post-endarterectomy, we're going to look for any flow disturbances, any restenosis of those vessels. Again, that neointimal hyperplasia. We want to identify progression of any contralateral diseases greater than 50% as well. So we also want to monitor, the presence of any disease on the other side, because at that point they may also need a endarterectomy on the other side as well.
So neointimal and myointimal are interchangeable?
They can be. Neointimal is more common when I see neointimal hyperplasia, so it's new. It is that middle layer that becomes thickened. But so if they removed a portion of that intimal layer, you're not going to see that intimal medial stripe in the internal carotid artery and that distal CCA. Sutures would appear very anechoic or echogenic, and that represent bright reflectors. So this was a post-carotid endarterectomy. So now we've seen some thickening of that vessel wall. And then also, so depending on, where that patient is along in their post-operative period, we would have to worry about that neointimal hyperplasia in their ICA. So if this patient, is like status post-endarterectomy, like 3, 4, 5 years they had it, then we worry about, the redevelopment of atherosclerotic plaque within that vessel as opposed to neointimal hyperplasia. But if, they're like, 6 months to a couple of years post-op, then that could potentially be neointimal hyperplasia. I think I've seen it as early as 3 months, they mentioned in one book. So think months to a couple of years, neointimal hyperplasia. Longer than a couple of years, it's restenosis from atherosclerotic plaque. So this is post-endarterectomy. Patient had a recurrent stenosis with elevated peak-systolic velocities of 200. After patch closure, blood flow abnormalities are corrected. And now they have velocities of 50 centimeters per second. So here you go. It's kind of like a little breakdown with after carotid endarterectomy. So in that early postoperative period, so a couple months after surgery, up to about 2 years, less than 2 years, we worry about that intimal hyperplasia or neointimal hyperplasia. Once we get after that 2-year period, 2, 3, 4, 3, 4, 5 years out, and then we worry about that reoccurrence of atherosclerotic plaque. If it's just focal, we can maybe do a stent, redo the surgery. If it's extensive, they might do another endarterectomy and a patch. Maybe they put in an interpositional graft. So this is why it's so important, in terms of complete occlusion. So when it's 100% occluded, there's nothing that they can do. But if you're up to 99%, there's still a little bit of flow getting through, they can try and reopen it. So carotid stents are easily visualized when you're imaging them. So you can tell when there's a stent in, you can see those echogenic lines, the double walls. You might look for malposition of stents or separation of the stent from that vessel. With the stents, we also worry about the neointimal hyperplasia, which can lead to restenosis within that early postoperative period. Again, once we get after, in that 3 years and beyond, it's then typically going to be atherosclerotic plaque buildup. That's restenosing that vessel. Patients who do have carotid stents, there's slightly different criteria. So some of these charts will also be posted in your vascular lab or wherever you're scanning. So this might be an example of one of these charts that you might see posted in your vascular lab. So there's a couple of different criteria depending on what your lab uses, but you're allowed higher velocities when we're talking about stented ICAs. So 50 to 69% doesn't come in until we get PC stock velocities of at least 225. If you use this method, at least 240. And then it's much higher when we're talking about the greater than 70% stenosis. So just realize when a patient has a stented ICA, expect to see higher velocities, and that's normal. There you can see the obvious carotid stent. So you can see that echogenic, stent within that ICA. So they're very obvious when a patient has a stent, being able to see it. So this is nice 2D. You can see exactly where that stent is. So here you can actually see all the long stent coursing through that ICA here. The echogenic border of the stent. So this was a recurrent high-grade stenosis greater than 75% of the patient's proximal ICA with elevated peak systolic velocities. And this was caused by neointimal hyperplasia. So again, it probably had to do with how long ago that patient had that stent placed. There you can see nice image, transverse patient stent. So they're very obvious, so you're not going to miss a stent in the carotid arteries. I can tell you that. And sagittal. So you can see again, very echogenic wall of those stents. So this actually, a patient had some thrombus within this stent here. So along the wall of that stent.
Was that the same patient, Dan?
No, I don't think so. I wish they showed a nice color picture for that. So ultrasound usage in an emergency. So for us, again, we can be used in patient triage. So we can use, we're readily available, portable, we have speed, so we can get to wherever we need to go fast. We have high temporal and spatial resolution, so we can see things in real time. Again, just our barriers, disadvantages for us in ultrasound, air, bone, body habitus, edema, all those things. With arterial supply, if the patient has a lot of collateral pathways around diseased vessels, we typically aren't able to get a good clear picture of all those collateral channels unless they do an angiography. So we don't image all those collateral pathways. So with carotid artery stenosis, we can determine that plaque morphology. So what type of plaque is it? So we're going to have a lecture just kind of getting into some of the different types of plaques, like smooth plaque versus ulcerated plaque versus hemorrhagic plaque, heterogeneous versus homogeneous plaque, calcified versus soft. So some of those different plaques are more susceptible to embolizing and breaking off and potentially being a source for TIAs or CVAs. So we can distinguish, acute carotid thrombosis versus stable chronic occlusion, where we get the slow vessel narrowing. We can be used in emergent situations when they have to do an emergency carotid endarterectomy. Patients could potentially develop acute carotid thrombosis. So the carotid artery could all of a sudden become acutely thrombosed. This could be a complication of a carotid endarterectomy or stenting in that immediate postoperative periods. So this may represent acute progression of carotid stenosis. Usually with this thrombosis, it's heterogeneous. It appears heterogeneous and echogenic. The vessel lumen of a normal caliber or slightly expanded. So the vessel is either going to be normal in diameter or slightly expanded. We might see sludge or swirling of flow at the interface of that thrombose area in the patent lumen. If it's, a vessel's thrombosed, we're going to see high impedance, so high resistant flow. So when we Doppler, we're probably going to see, that systolic thumping. We might even see some bidirectional flow where it hits that clot and reverses back. If the thrombus is free floating or moving around, that means that it's a very high risk for embolization. So we'd worry about, that potential for that patient, stroking out on us. So that would be a serious thing. If we see internalization of that ECA, so if that ECA becomes low resistant, that could potentially indicate that there's some sort of acute carotid thrombosis, maybe in that distal ICA higher up, because the body hasn't had sufficient time to develop collateral channels. So maybe a clot, got ejected from the heart, maybe went up the patient's left ICA up and is lodged somewhere in the ICA intracranial. When we're Dopplering now, we see that external carotid artery has become what's called internalized, taking on the characteristics of the internal carotid artery. So it's now low resistance. That could be, that could indicate, this potential thrombosis of that vessel higher up because that the body hasn't had a chance to develop sufficient collateral flow. So it's going to steal it right away from that ECA. So that's
isn't this, sorry, I didn't mean to interrupt you.
That's okay.
Isn't this saying that the internalization of the ECA is not seen though?
Yeah. Oh, I'm sorry. Yeah. Oh man, I'm out of it.
No, you're all
Internalization
right.
of the ECA is not seen. Sorry.
Because yeah, I mean, you were describing
Yeah,
how it's
yeah, no, I was
internalized
describing
in
something
previous
else. I'm
slides.
sorry. Yeah, I'm sorry.
No,
So internalization
you're
is
not
seen.
well, so it's okay.
Yeah. So I'm just gonna, let's see. So just showing carotid artery thrombosis. So you could obviously tell this vessel is completely thrombosed. So thrombus within that vessel is very obvious. It's gonna look like a DVT. It's gonna be kind of like that spongy appearance. So just think a blood clot, within that carotid artery. And this is that water hammer sign at that interface between the patent lumen and the acute thrombosis. There's a hammer-like to and fro waveform. So this was demonstrating some potential free-floating thrombus that's adherent to the walls and maybe moving around back and forth within the bloodstream in real time. Carotid artery dissections. So these result from hemorrhage from the carotid wall. The medial layer is the most common location and may extend to the subintimal layers. So we might have thrombosis seen in that false lumen. Carotid dissections can also lead to aneurysm. Some symptoms include neck pain, headache, tinnitus, which is ringing in the ears, or any sort of focal neurological deficits. Carotid dissections could be spontaneous. They could be idiopathic. So we don't really know why it happened. It could be due to trauma, maybe blunt trauma, penetrating injury, or catheter injuries. Or could be associated with some of our patients that have those connective tissue disorders like Ehlers-Danlos, Marfan's, and FMD, the fibromuscular dysplasia. So the mean age for carotid dissection is about 40 years. It's more common in males. Dissections of the intracranial ICA are associated with a 75% mortality rate. So kind of counterintuitive to what you might think. If you have a dissection of a smaller vessel, so say something intracranial, if there's a dissection of a smaller vessel, this is more significant than having a dissection of a larger vessel. So when you have the dissection of smaller vessels, that true lumen is much, much smaller and there's much less blood flow getting through. So that has a more significant impact than having a dissection on a larger vessel. So with the dissection, we might see high resistant waveform with reduced flow velocities in that ICA. This is our, picture we'd expect to see with a carotid dissection. We look for that intimal flap and transverse going across that vessel. And then in sagittal, we can see that intimal flap extending across the vessel and separating it into a true and false lumen. So in this case, that false lumen is much larger than that true lumen. And here you can see another carotid artery dissection. And in sagittal, we see two channels of flow, one red, one blue.
Dan,
Wait, how-
Yep.
It's
or go ahead, Sydney.
I know. Thank you. Anyways, how can you tell if it's a true lumen?
How can you tell? You'd have to Doppler.
Yeah, that's what- but
Yeah,
isn't the
so
false thing though?
so you'd have to go based on your color flow and your flow direction. So if this is my carotid artery and this is blue and it's flowing away from me, that's got to be the false lumen if it's retrograde flow, and then this be your true lumen if this is the correct flow direction. But Dopplering, you'd be able to tell. With the Doppler, you'd have what looks like a semi-normal carotid waveform versus something that looks completely abnormal and retrograde. And Yeah, so you just have to know the flow direction. So the true lumen is going to continue going up to the brain. The false lumen, you could have retrograde flow. If it's not retrograde flow, it'd be a very dampened, you know, abnormal looking waveform. You do Doppler and be like, no, that's not normal. That's got to be the false lumen. Just remember the false lumen could eventually become thrombose. So then you might see thrombus formation within that false lumen. Usually the false lumen is larger in diameter, to be honest. So this case, this was the false lumen as well. It's larger in diameter, but Dopplering is really the ultimate way in knowing your flow direction. So the true lumen is going to continue with antigrade flow, whereas the false lumen, you could have retrograde flow in it.
Okay, when you were talking, Dan, right before this, you were talking about how it was worse if it was an internal.
Yeah, if it's a smaller vessel that's dissected, it's worse for the patient. Like they'll have more severe symptoms, just because that vessel now is that much more narrow.
Okay, gotcha.
So it severely diminishes the blood flow in that area when you have a dissection on a smaller vessel as opposed to a larger vessel. So it's
And so when it says dissection of intracranial ICA associated with 75% mortality, so is that what you're describing?
yes, yeah. So it's worse for the patient. It's
Okay.
worse outcome. Yeah. They exhibit more severe symptoms. I actually have to jump off and get to my meeting with Botswana.
Have fun with that. Sounds cool.
Yeah, right. I'll see
What's
you guys.
Botswana?
I'm meeting with this international delegation from Botswana about they want information on starting up a program, an ultrasound program.
Oh wow.
They're
Okay.
like they'll text me, like throw me into that. They didn't give me much details until the other day. I'm like, what is this? Like, oh no, yeah, we just need you to talk to them. And
Wow. Okay.
that's just funny. All right.
Thanks for doing this, Dan. Hope you feel better.
Thank you. I'll be
Thank
in
you, Dave.
touch. Take care.
Thanks.
See you guys.
Bye.